Dynamic anterior stabilization. This is a new kit to manage recurrent instability for shoulder in patient where you have a subcritical bone loss of between 10 to 20% off tract Hill sacks. You can do it in any age. I prefer to do it in lateral position, standard posterior, antero-superior, antero-inferior, and anterolateral portal extra you need for this technique. The whole principle is you do lethargy, most of the time the bone gets absorbed and you believe in the sling principle of the conjoint tendon. What you do, you remove the biceps intra-articularly and reroute it through the subscap and attach it on the glenoid so that it acts as a dynamic sling, and that is called as dynamic anterior stabilization. So viewing from the posterior portal, the subscap is completely intact. You can see there is no labrum anteriorly, intact subcap. The biceps tendon is also intact, complete, and you see a huge Hill sacks lesion, which is an off-track and quite medialized Hill sacks lesion. The next step is to form this anterolateral portal just anterior to the anterior part of the supraspinatus tendon and exactly on the bicipital groove. The next, you have to make an antero-inferior portal. The trajectory of each should be around 5:30, not exactly at 6 o'clock, because you are not going to put any anchor at 6 o'clock. Then with your RF, you have to cut the middle glenohumeral ligament and create the space between the conjoint tendon, coracoid, anterior to the subscap, and also clear a bit amount of capsule posterior to the subscap till you see some muscle fibers of the subscapularis. So as you see here, you see some muscle fibers. So that is what you need to release. Then through the antero-inferior portal, you have to make a rent into the subscapularis with the help of your switching stick at the junction of upper 1/3 and lower 2/3. Then with the help of your RF probe, you create a rent from the medial to the lateral aspect of the subscapularis. The way you do your lethargy, you make a horizontal cut in the subscapularis from medial to lateral. The same you are making arthroscopically from medial to lateral, viewing from the antero-superior portal, showing some amount of glenoid bone loss. Now a double-loaded all-suture anchor is taken and it is passed through the rent into the subscapularis muscle onto the 5:30 position. You retrieve all the threads from the antero-superior portal and you take bite with the help of self-biting instrument or self-retrieving. All the 4 sutures has to be taken a bite through the substance of biceps tendon, which is little distal, which is little lateral from the infraglenoid tubercle. So first anchor, double loaded, all 4 bites in some horizontal, some haphazard fashion, not in one line, has to be taken through the biceps tendon. As you see, 1, 2, 3, 4. All 4 bites through the biceps tendon and then park it into the anterolateral portal. Once you park it there into the anterolateral portal, the next step is to put another double-loaded anchor at 4:30 position. Double-loaded all suture anchor. You can use simple knotless suture anchors as well. Again, you have to take the 4 bite into the biceps tendon, but medial to the first 4 bite. So you have taken 8 bites in the bicep tendons, first for 4 of the first anchor. Then you have to knot 1 blue and 1 white. Don't tie the same anchors. 1 blue and 1 white of distal anchor and 1 blue and 1 white of the proximal anchor. Knot is taken and it is cut. Then remaining 2 suture limbs of both the anchors are retrieved from the antero-inferior portal. This is important. Tie different loops, not the same loops. Once you finish tying this, then you do biceps stenotomy. After you finish your biceps stenotomy, you need to release the transverse humeral ligament from the bicipital groove so that you are able to sublux or dislocate the biceps tendon out of the bicipital groove. So gently see that the RF is not towards the biceps tendon so that you don't damage the biceps tendon. You gently release the biceps and then you start pulling 1 blue and 1 white, and automatically the biceps is delivered through the subscap onto the glenoid, and then you again tie one blue and one white of the distal anchor and one blue and one white of the proximal anchor, and you stabilize the fixation of the biceps onto the anterior-inferior glenoid through the subscapularis. And once you finish that, you can see that the biceps going through the subscap, and it acts as a dynamic pulley to prevent recurrent dislocation. View from the anterolateral portal, this is the bicipital groove, that's the glenoid, the complete empty bicipital groove, and this is the biceps tendon, which has been rerouted outside the bicipital groove through the subscapularis. This is subscapularis, here is the rent, and through the subscapularis rent, it is gone, and we have attached it onto the glenoid. This is the view from the anterior superior portal. This is the biceps tendon, this is the subscap, and that's the dynamic anterior stabilization. So this is the way you do DAS technique for recurrent shoulder instability. Thank you.
Thank you.
One of the common problems that people encounter in ACL surgery is figuring out if the guide wire is in the tibial tunnel screw hole or not. So we devised a little trick that allows us to figure out whether the guide wire is in the screw tunnel or it's outside of the screw tunnel. So I'll show you how we do it. So we put the guide wire into our tunnel. So sometimes you're unsure whether it's in the right place or not, if you've captured some soft tissue. And then what we do is we flick the guide wire like this. So this is known as the early morning test. And if it bounces nicely, then that means you're centered in the tunnel, and that way your screw is going to go in the trajectory that you want it to go and not deviate from that pathway. Thank you.